we're rounding out things. Many of you, I want to thank all of you for sending in questions with respect to the chat window. For those in person, Dr. Dubs has the lavalier that she'll be able to walk around. So I have many, many questions from our colleagues online, but let me first open up questions for our panel for those sitting here in Leadership Hall. Any tox questions? Resuscitating for 2, right ventricle, hemoptysis. As you'll see, Dr. Sutherland just finished because he jetted back off. He's called back to the MICU. So he is on service and things are quite active in the MICU today. So, all right, so I'll start things off with several questions that came in online. What I will say is while I'll ask specific questions, all 4 of you, please feel free to chime in terms of your expertise and experience. So going back to Caleb, starting the morning for us with respect to massive hemoptysis, is there any role, you talked about inhaled or nebulized TXA, any role for giving IV TXA?
Great question. So there have been some studies with IV TXA too. There was one actually with IV versus placebo, and it did show decreased rates of hemoptysis and I think a subjective score in terms of how much hemoptysis there was, but it wasn't actually quantified. But I think also one distinguishing factor that I had mentioned before is that these studies were not conducted in patients with massive hemoptysis. It was submassive or kind of varying degrees of hemoptysis. So you kind of have to take that with a grain of salt. And as well, IVTXA, I think we all know there are other side effects that you need to worry about sometimes as well in terms of thrombosis. And so I think the data for nebulized TXA, again, not necessarily a massive hemoptysis, is a little bit more robust. And there was a recent study that also came out as well.
All right, outstanding. Dr. King, question came in with respect to the sick patient who presents bradycardic from calcium channel blocker overdose or beta blocker overdose. Would you recommend, or is there a role for transcutaneous pacing?
Yeah, that's a great question. If I were asked that a decade ago, I would have said no. And that's because the conventional teaching is that these patients may have failure to capture, meaning you put in your pacer, you turn up the lead, and you're like, they're still bradycardic. The pacer doesn't actually capture, and kind of the mechanism for that is the same as the mechanism of the drug. You're poisoning the mechanisms that would lead to the propagation of that zap leading to a heartbeat. But practically, over the past decade, I have actually seen a number of patients who did get paced despite that conventional knowledge, and yeah, it worked. So I would say that there is a role. It is on our, the Maryland Poison Center, as do many other poison centers and toxicology groups, have standardized guidelines that we send out for calcium channel blocker overdose. We reviewed them a few years ago. And yeah, pacing's on there. So the thing that I would bear in mind with pacing is that it's not going to fix your inotropy problem. It's just going to fix your chronotropy problem. So I wouldn't use it first line. But if you have a patient who has refractory bradycardia, I think it's absolutely worth considering.
Great. Dr. Hu?
I've never paced a patient with the severe calcium channel blocker, beta blocker overdose. I'm wondering if you would recommend an attempt with something like atropine or isoproterenol to see if there's a utility in that rather than going for an invasive procedure.
It's again a great question. Atropine is on the said guidelines, but it's really early on. So the issue is, so atropine makes your patient anticholinergic, right? In other words, and I'm not so much worried about anticholinergic delirium there, although it's fun to make the mumbling sounds where you say, the patient will say, it's a very characteristic sound. If you ever heard it, you know what I'm talking about. Anyway, the issue is that giving a beta blocker or a calcium channel blocker is almost like a sympatholytic toxidrome, in that now when you give an anticholinergic, you remove sympathetic tone. So you say, all right, awesome. Now we've got a resting sympathetic tone that's going to drive the heart rate. But that's poison too. So in other words, yeah, we'll use it primarily for beta blocker and more commonly for so-called therapeutic misadventures, such as patients' beta blocker dose was recently increased and now they're bradycardic, and you give a dose of atropine and they get better. Less so for the intentional substantial overdose. In my experience, at least, it doesn't tend to work very well.
Additional questions before I move on? All right. Dr. Hu, in terms of intubating the pregnant patient, you highlighted a number of great pearls with respect to making a more difficult or challenging airway. Any pearls for how to go about actually your, say, plan A, B, and C for actually doing the procedure?
Without being too repetitive, I think a big part of it is the mental preparation and your setup before doing it. I sort of alluded to, this is not, if you have the option, this isn't a crash intubation, something that you want. You may need to have, in essence, a slightly lower threshold to intubate somebody because you don't want it to be a crash intubation. You want it to be very controlled. Having been party to, again, we had a lot of COVID infected pregnant patients in our MICU. We had the luxury of having, I'm sort of going off on a tangent here, I apologize. We had the luxury of having, obstetricians at the ready when a patient was decompensating, if they were particularly hypoxic or we were concerned that something was going to go awry. So that's just a sort of another side note. If you do have a patient who is doing poorly from an oxygenation standpoint, and it may be that they need to deliver, calling your OB team to be ready peri-intubation is another sort of tip to have in your back pocket. If you don't have that, you don't have that. But it's really setting yourself up for success. So I cannot overemphasize the rate at which these patients desaturate when you supine them. If you can avoid supining them at all, please do. So whether that's your ramp position or having them in reverse Trendelenburg, it really does. When you take away their respiratory drive, they desaturate very fast. And again, you have a lower tolerance for desaturation. You're really not trying to drop below 92. They are not patients that if you have the opportunity, I would not bag them a long time. If you're pre-oxygenating with non-invasive or your high flow, do it that way. Again, that also speaks to not waiting till it's a crash intubation. You want them to be as oxygenated as possible, and you don't want to have to bag them a lot due to those risks for gastric overdistension and aspiration during your airway, which would be catastrophic. And again, having your adjuncts ready to go and having a backup plan sort of as alluded to. So have your bougie ready to go, utilizing, we as intensivists like having the larger ET tubes because you can bronch through, you can do, diagnostic and therapeutic treatments through, but really you're just trying to make sure this airway goes in. So those smaller airways to set yourself up for success are going to be really key. And I think at a teaching institution, it always comes off a little bit poorly to say this is not one for the trainees to try, but really if you're talking about trying to make sure you're optimizing the outcomes for a pregnant patient and the fetus, this is really the most experienced intubator who is going to be the most ready to make decisions in the moment as well if it's not going well. I don't know if that fully answered the question.
I think so. Thanks. Dr. Siklacha, two-part question. With respect to patients with pulmonary hypertension or acute pulmonary hypertension, what is your preferred vasopressor? And with respect to inotropic use, is milrinone the preferred inotrope for these patients?
So my preferred vasopressor off the bat is typically norepinephrine, just because of the ease of titratability and our institutional experience with it. Depending on the cause of their pulmonary hypertension, so the pulmonary arterial hypertensives, vasopressin is probably a little more attractive. And if their blood pressure is normal, in the long run, milrinone probably has better evidence. In this institution, and my practice is to typically start with epinephrine. The inotropic dose really begins, at 0 and then goes up to 0.05 mics per kilo per minute or about 5 mics a minute, depending on how you titrate it. but you get most of the increase in your cardiac output in the first 0.02 mics per kilo per minute, and it sort of has a flatter rating curve as it becomes more of an inopressor. And so that's what we tend to start with here, norepinephrine and then low-dose epi. And depending on the underlying disease, especially if they have diastolic dysfunction or fairly isolated pulmonary arterial hypertension, not necessarily something like a PE, then milrinone becomes really attractive. You just have to be ready because in their shock state, they will retain that drug, and you'll have to make sure that you have some sort of vasopressor on board to avoid systemic hypotension. So probably milrinone makes the most physiologic sense, but practically it's a little more difficult. So off the bat, often norepi and epi, and then depending on the underlying disease, potentially moving towards vasopressin and milrinone if it's really primary pulmonary arterial hypertension.
Outstanding. Well, there was another one in the chat window on specifically milrinone, and because it's maybe you mentioned technically challenging, how do you titrate that?
So depending on how much of a boost you're trying to need, you can do a faster initial infusion rate and then titrate it back off. So something like 0.375 and dial it back as you get closer to the inotropic goal. We often kind of underdose milrinone because of the concerns for vasodilation. So typically an initiation dose is 0.125 and titrating up. It will take a little while for that to reach steady state, but often the manufacturer's instructions and a lot of the lab evidence really looks at much higher doses, up to 0.75 in some of the guidelines. But I think if you're less familiar with the drug, probably starting at 0.125 in addition to something shorter acting, and it's going to be difficult to titrate that clinically. And so that's where often these patients, if you're looking at adding a second inotrope, really need a swan in so that you can understand what you're seeing, or some sort of TEE or even continuous cardiac output.
Great. Additional comments?
I have additional questions, actually, I mean, lots, but both for Dr. Sajloka and Dr. Hu. Since we're talking about MAPS, again, other than tox, I'm renal. So right after I write obligatory avoid nephrotoxins in my, AKI consults, I'm writing keep MAP above 70 because kidneys seem to like higher MAPs. And I am curious in either the patient with any pulmonary hypertension or in pregnancy if there's any benefit to MAPs above 65. I write that in my consults, and then I go look at the sepsis literature that says better outcomes for kidneys, worse outcome for everything else, and you have 65 as a reason for most, but what about in these subsets?
Nicely done. I think it really to me is about perfusion, and there's numbers at which you lose autoregulation. So a lot of times we will push MAPs in spinal cord injury because of the nature of that system being less autoregulated. But to me, I tend to push higher MAPs in patients who have fairly isolated RV failure. So not the people who have biventricular failure where you're really afterloading a struggling LV, but patients who have more isolated RV failure, acute pulmonary hypertension, I'll increase their MAPs, especially if their CVP is very high, and try to shoot for a perfusion pressure of something like 55 or 60 with an evidence base of I've seen it work. And then it really becomes to me about decongesting and dialing off their CVP. That's why it can be very uncomfortable to give 160 milligrams of Lasix and start CRT in someone who's on 1.0 of norepi and max inotropes. And that's where I think you have to really get comfortable with recognizing when your treatment is working, which is why serial, echo evaluation, serial organ dysfunction, even labs, right? It's kind of the old school way of doing this is really looking, are their LFTs getting better? Because the LFT bump in heart failure is really related to the congestion from the venous side. And you'll start having more confidence as their LFTs are getting better. That's hard to do acutely in the ED.
Yeah, that I guess sort of segueing off of what you said. You mentioned it, but we were talking about titrating your milrinone or your inotropes, you can wait the however pre-specified period of time because this patient is boarding in your ED now for how many hours. If you have that upper line, we're not putting in a bunch of swans in the emergency department, but you can check, an SCVO2, to kind of get a sense of what your central venous gas might be and tell you if your inotropy is enough. And then I always caveat the epinephrine, right? So if your issue is, epinephrine, I would say if you had one thing that you could use and your emergency department is familiar with epi, go epi, right? Like you don't want to introduce necessarily new medication that your nurse, who is not maybe your room around the corner, your nurse isn't familiar with, you're not really sure what to do with. But in RV failure, right, as Dr. Suklacha very expertly produce up there, most of the time it's an RV afterload problem. And so he talked about sticking with those inotropic doses of epinephrine. If you start to outstrip that or go beyond that, that does not help you. That actually causes pulmonary vasoconstriction and increases your afterload. So just being wary of some of those things. And then for the pregnancy map, there are no studies comparing different maps in pregnant patients. And so the general recommendation follows general guidelines for the rest of the population, a map of greater than 65. But the Society for Maternal Fetal Medicine does recommend a individualized approach to their blood pressure. And so this may be where you need to Google, what's their blood pressure supposed to be right now in this trimester of pregnancy, right? We sort of talk about in a healthy patient, that nadir sometime in the second trimester. So they may be 80s over 50s, and that may be fine for them. You don't necessarily need to do a lot of, fluid resuscitation or pressors if they're not volume down. That's how pregnant people kind of get you. They could be septic, they could be fine. So you have to have a high threshold. You have to really investigate your patient. If you have clinic data, magically, they follow at your institution and you can see what their blood pressures have run, that might be helpful. And then also remembering relative hypotension in patients who have chronic hypertension in pregnancy can always muck up your blood pressure assessment as well. Or if they have, if they're preeclamptic, those patients can still be septic. So you just have to kind of keep those things in mind. But in general, greater than 65.
All right. So while we didn't have a talk on ECMO, there were components and mentions of ECMO for several of the disease states and critical care cases we talked about today. Dr. Chan, I'm going to circle back to a question that came in with respect to massive hemoptysis and the potential for moving down the pathway and maybe going to ECMO for resuscitation. How do you balance initiating ECMO in that patient, knowing that you have to provide systemic anticoagulation with massive hemoptysis?
So I'll let Lucas speak a little bit as well. But so there's different kinds of ECMO. So VV versus VA. And specifically for VV ECMO, you don't necessarily actually need to anticoagulate these patients. And so in a patient with massive hemoptysis, obviously that would be ideal. On a side note, obviously not a patient that you're going to be running into the emergency department or running into in the emergency department, but VV ECMO can cause massive hemoptysis too, because you can have some acquired coagulopathies as well. But just to answer that question, for a VV ECMO, if that's particularly why this patient is being cannulated, you don't necessarily have to start them on systemic anticoagulation.
You threw it over to Lucas. Did you want to make a comment?
I want to make sure, because we're talking about massive hemoptysis primarily.
Correct.
Yeah, and that's where you can do VV initiation without much systemic anticoagulation. You want to at least be able to heparinize your cannulas. And we also see it much more commonly actually in our patients who are already on ECMO who have horrible destructive lung disease, and they'll often be eventually have something eroding into their bronchial arteries, and their whole lung will just become one big cast, and we'll have IP come and pick clot out for days. And so our experience with putting people on ECMO for massive hemoptysis is a lot less than our experience with patients who are already on ECMO for something like a necrotizing pneumonia who then develop massive hemoptysis. The one difficulty with that is you have to think of what your exit strategy is from ECMO. So it can't just be, boy, they're really sick. And sometimes we do that where it's a bridge to decision about therapy or candidacy for transplant. But there's got to be some sort of step to try to liberate them from ECMO in the future. And so that's where the teams really think about, is there an exit strategy for this person? And often the people with massive hemoptysis from just an isolated bronchial artery bleed, some trauma, they can do really well. But the ones with recurrent massive hemoptysis are really ones who have destructive lung disease that may never be able to separate from ECMO without transplant. Oh, I see a question in the back from Dr. Dubs.
Thanks. So we had a massive hemoptysis patient a few weeks ago, a month ago or so, intubated in the ED, high five. Super happy about that. The patient had known lung cancer and their tumor essentially had eroded. And so they were having the massive hemoptysis from that. Classically, we are taught, to try to main stem the tube. What vent changes, if any, would you do, or like how would you set the vent up in a situation like that?
Yeah, and we can keep passing it down, but I think the big thing is to pay attention to your pressures and make sure that you've actually gotten in the place that you're trying to go. But then also be mindful, if you have suddenly got good returns, good end tidal, and you're not actually getting any blood back, and you have some confidence that you're ventilating the good lung, then it's just paying attention to your pressures. Particularly, I tend to just put those patients on pressure control and follow their end tidals. I don't know what others do. I will, if they're still having blood back, volume control is obviously the safest because of the risk of obstruction. But if we really feel like we've successfully isolated, we're trying to avoid overdistension, I'll sort of balance back and forth, trying to dial in pressures and see what's not going to injure the good lung, because that's obviously their prospect for recovery.
Yeah, I think this is primarily just single lung ventilation. It's like single lung ventilation, right? So you don't want to deliver the same amount of tidal volume that you would for two lungs. You don't necessarily, go halvesies. you do have to kind of follow, if you have end tidal available, the patient's hooked up, you just like Lucas said, or Dr. Scalacci said, you can dial in a particular volume or pressure for a certain volume and see what that does to your end tidals, and if your clearance is high. Tolerating additionally some permissive hypercapnia there in the setting of single lung ventilation is very reasonable.
Just in terms of pressures that you're looking for, so make sure you go off your plateau pressures and not your peak pressures. Obviously, if you have an elevated plateau pressure, you're going to have an elevated peak pressure as well. But if it's purely peak and not a plateau, and again, this is a whole other talk, and the interns that rotate with me in the NICU, we talk about this all the time. But that peak pressure in a normal plateau is going to be because of airway resistance. So whether there's a clot that's formed somewhere in the airway or along the ET tube, that's what can happen. And again, just to reiterate from my talk, you got to make sure that pressure alarm limit. So there's a number that the RT will set. It's typically as high as maybe like 40 or something like that. The vent will alarm if it hits that peak pressure. The problem is that a lot of these vents, so for PRVC or often for volume control as well, depending on whatever vent you're using, if it hits that alarm, it'll actually cut off the breath that it's giving. And so even if you set a certain tidal volume, say you're set 400, if it hits that alarm before that volume gets reached, that patient will only get whatever volume it's there. It's like 100. So I've had patients where that wasn't really paid attention to, and so they're actually getting underventilated. So yeah, track your end tidal, monitor your plateaus. And then one other thing to know is just if you are main stemming your right, as a right main stem intubation, the right upper lobe takeoff is fairly close. And so you can actually occlude both. And that patient, you're going to have some issues. You might have some issues ventilating that patient as well. Again, hard to know in the moment. If you don't have a bronchoscope, you're kind of doing your best. But that is a risk of main stemming the right.
Caleb, before we leave that, there was also another question in the chat about that. If you are adjusting and elevating the threshold for ventilator alarms, is there a risk of maybe not recognizing complications of ventilation, such as a pneumothorax that might be worsening?
Oh, I mean, absolutely, right? I mean, if you are main stemming this patient or you're having runs issues, there's certainly, a risk for that. Again, this is why, right, we don't set it and forget it. I know emergency department, things get busy. Obviously, there's other patients that are coming in, but if things change, right, this patient that you're going back to reevaluate. This is not someone that you're just, leaving in the corner, but you're checking on often, getting, again, your consultants on board to help out.
And before we leave ECMO, passing it down to Dr. King, a question came in regarding the use of ECMO for, I believe, the second case, the calcium channel blocker overdose.
Yeah, in fact, that's probably our most common use of ECMO for the poison patient, for calcium channel blocker poisoning. A caveat in amlodipine. So your non-dihydropyridine, so diltiazem, verapamil, these are the ones most likely to cause low ejection fraction cardiogenic shock. You have LV dysfunction, your cardiac surgeon comes and they look at the ECMO and the echo and it's going like this, right? This is a good candidate for ECMO. But these patients, I would argue, compared to many others, have a pretty good chance of survival, depending on their pre-existing conditions and their age, despite multi-organ failure, just simply because you have a reversible cause in the poisoning. Amlodipine's the tricky one. So amlodipine is a really potent vasodilator. It inhibits nitric oxide synthase. And what you end up with is a lot of the times a patient who is actually hyperdynamic, EF greater than 70%. That LV's doing fine. It's just the potent vasodilation. And we have had patients transferred to University of Maryland Medical Center looking for potential ECMO and then don't get it because they're hyperdynamic, and instead what we end up doing is giving more vasoconstrictors. So whether that's methylene blue, whether that's just maxing out conventional pressors, including angiotensin II. But that being said, anyone who has an LV that's working that hard in the setting of poisoning can eventually develop LV dysfunction. And we have had patients with amlodipine poisoning go from hyperdynamic EF to a left ventricle that isn't doing so well and eventually needing ECMO. So long story short, yes, we do consider this. And in fact, if you have a patient at a hospital that cannot perform ECMO, one of the things we try to consider early on for the sicker ones is whether they might benefit from transfer to a center that can do it.
All right, down the line to Dr. Siklacha again. In terms of resuscitating patients with acute pulmonary hypertension or acute decompensation of chronic pulmonary hypertension, the utilization of inhaled vasodilators. One of our attendees wrote in with respect to having iloprost at their organization. Can that be used? Is that useful?
I don't have as much experience with iloprost. I'm not sure if it's actually on the list of some of the pulmonary selective vasodilators. So I would have to defer that question about iloprost. It's just not a medication that I use, but epoprostenol, treprostinol. There are other things you can use in low resource settings as well. There are case reports of nebulized milrinone, which I've actually done a couple times now, and nebulized nitroglycerin. But that really is kind of an extreme circumstance. And I think all the other supportive care is going to be important. I think the inhaled pulmonary vasodilators are a little difficult in terms of resource mobilization. So I would have to check back on iloprost, but if it has essentially the same FDA label as epoprostenol, often one place because of the expense and the setup, we'll just have one agent.
Thanks. If we have, by chance, any ED pharmacists who in the crowd that want to make any comments,
yeah,
the floor is open.
I see.
All right.
See Ashley.
I think just some final questions here. A few more, or one more for Dr. King in terms of the initial case with the toxic alcohol, more commonly seen alcoholic ketoacidosis. Are there any additional pearls? Is there any potential metabolite that can still help us differentiate when we have someone with AKA versus a toxic alcohol?
Yeah, I'll be honest, it's really tough. That's part of the reason why nowadays focus more on history, focus on maybe the degree of osmolar gap. one of the counterintuitive things that we have found is that patients who have alcoholic ketoacidosis or non-toxic alcohol poisoning causing osmolar gap and anion gap, they're more likely to have acute kidney injury. And maybe that's because the patient has been sicker for a longer period of time. If you ingest a toxic alcohol, it does not take long. I regret to tell you, we've had patients who less than 24 hours from methanol ingestion have had brain death. It doesn't take long to have very severe effects, but it can take longer with starvation or alcoholic ketoacidosis. The other thing is that I guess it's not exactly a metabolite measurement, but it sort of kind of is. That elevated creatinine might actually be due to false interference with the creatinine assay. So the creatinine assay is something called the Jaffe reaction. It's done in maybe 2/3 of labs nowadays. Used to be more, but we see still clinically, you see it all the time where acetone will falsely elevate your serum creatinine. Classically, we see that with alcohol poisoning, where isopropyl alcohol gets metabolized to acetone. And if you have a patient presenting extremely inebriated, ethanol level is negative, BUN is 4, creatinine is 2, and yet they're urinating very well, that's your picture for a patient who just drank isopropyl alcohol, which doesn't get metabolized to a carboxylic acid metabolite, but makes you drunk as a skunk. It's about twice as inebriating as ethanol. That's the best I have. I wish that there were a better way to do it. The most recent X-Trip guidelines we talked about for ethylene glycol talk about making a plea for clinical labs to start measuring ethylene glycol and methanol directly. And really, all of this stuff we're talking about is because we can't get it in real time. In our area, it all gets sent out to a reference lab, and usually it's Quest and Chantilly, and they'll get back to you in 2 or 3 days. So that doesn't help you in the ED. What is really needed is better availability of regional and local ethylene glycol testing.
Dr. Bond, I'm going to turn to you. Have there been any additional questions that have come in the chat window? Dr. Dubs, maybe the lavalier.
There's one question. It's for Cami Hu. The question basically was, now that ambulances are carrying blood products, and if there is a mother that's a trauma patient, is there any downside to giving them the generic blood product that they have on the ambulance?
I don't know the data specifically related to that in pregnancy, and I would have to defer to Dr. Siklacha for his trauma experience. But in general, my understanding is dependent on what the blood product is that they have available in trauma patients pre-hospital.
We have primarily O-negative whole blood, which is what's going out pre-hospital. Other programs use low titer O-positive whole blood. And part of some of those blood programs is they've all developed a particular surveillance strategy to prevent alloimmunization. And often we'll give those patients large doses of Virogram, but some of the data is actually pretty encouraging that a unit of blood as opposed to a small maternal fetal hemorrhage is actually such a big antigen load that the risk of tolerization or the risk of sensitization is probably actually less than maternal fetal hemorrhage for patients getting transfusion, especially massive transfusion. And so part of those programs, when you're starting a whole blood or a pre-hospital blood program, is making a decision: will you use O negative or O positive, and what's your surveillance going to be when you're giving it to female patients or patients who can get pregnant and risk alloimmunization? And so that's part of the quality control for some of those programs. I think San Antonio has probably the best developed system that's accessible online for how they do their follow-up.
Would you mind expanding on that a little bit? Maybe I'm just simple, but so a whole unit of blood has less chance of causing antibodies than just a little maternal fetal hemorrhage? That seems so counterintuitive. I'm having trouble absorbing that.
Yeah, it's it's not entirely clear, but there's a relatively low risk based on some of the trauma literature and some of this follow-up that alloimmunization with such a big antigen load, there's some preclinical data, registry data. It's difficult because following up those patients long enough for future pregnancy, but biochemical tests are sort of suggestive that a large unit of blood isn't necessarily more likely to cause sensitization than a maternal fetal hemorrhage.
Let me ask, are there any additional questions from everyone in attendance? All right, well, we were just minutes away of really our time together here for our 10th annual Critical Care Symposium. I want to send a huge thanks to Dr. Brown and Dr. Mathieu for supporting education and their focus within this department of providing really exceptional education. A huge thanks to Doreen Lucadamo. She's sitting outside. I know those of you online can't directly thank her, but I'd encourage all of you here to send Doreen a really heartfelt thanks that she has put in weeks of many and countless hours with respect to doing all the legwork behind the scene to prepare this particular day. Dr. Bond, a huge thanks for running the AV along with Dr. Myers, really outstanding work, connecting all of us and troubleshooting super quickly online with some sound issues along with imaging issues. Really outstanding work. I'd like to thank Dr. Siklacha, Dr. Hu, Dr. Chan, Dr. King, Dr. Sutherland, as well as Dr. Marcolini. You really have given us outstanding pearls for really super sick patients on the even far end of the spectrum of the critically ill patients we resuscitate each day in our emergency departments, regardless of our location.